Thank you for joining us today for the lunchtime seminar, and it's a very special seminar because we have as our speaker Professor Julian Savulescu, who is in Singapore, having braved the twists and turns of COVID regulations to be here for, I think, a little more than a week. So Julian has flown in from Oxford, where, as you know, he holds the Uhiro Chair in Practical Ethics at the University of Oxford, and he's going to go on after this to Australia. He, for various reasons, spent Christmas there, and also he holds appointments, as you know, in the University of Melbourne and in Murdoch. Now, I've promised to keep this introduction very short because we want to spend most of the time this hour listening to Julian and then having a question and answer at the end, which Owen has kindly agreed to facilitate. So perhaps just let me say that you know, anyone among us who has been following the bioethics literature will be very familiar with Julian's work, and you'll also know that he has published very widely across a very broad range of topics and interests. But recently, of course, he's published extensively on COVID vaccination, and it's in the area of COVID vaccination and other issues that he's chosen to address today. So we very much look forward to your talk, Julian, and especially since, you know, the COVID almost waylaid plans once and almost twice for you to be here. I think it's with significant relief and great pleasure that I'd like to invite you to speak to us now on this topic, ventilators and vaccines, lessons from the pandemic. So Julian, please.
Okay, thanks very much, Adeline. It's a great privilege to be here, and I would really like to thank Adeline, but especially Connie Wu and Rebecca Tan for navigating the extraordinary kind of obstacles to me coming here, and so I would really like to thank them especially. So I want to talk about some work I've been doing with mainly Dominic Wilkinson, but also Johnny Pugh and Alberto Giubilini. So this will be a fairly kind of lay talk, but we'll give you an idea about the way we're doing things in Oxford and some of the conclusions that we've come to, because we're sort of, if you like, pioneering a sort of new way of thinking about ethical issues. And so Owen's heard this before, but I think that there have been two great ethical issues in the pandemic, which have been largely unaddressed and fudged. And the first one is the value of life and the allocation of life-saving resources. So that could be PPE, hospital beds, oxygen, ventilators, ECMO, or vaccines. So when we have more people who need a life-saving resource than we have resource, how should we decide? And so there's been a resolute resistance to developing a principled way of answering that question. And that's going to be the first part of the talk. And the second main ethical issue is about how to weigh different values. For example, weighing public health or well-being versus liberty or freedom. And that's behind issues such as quarantine, lockdown, mandatory vaccination, vaccine passports. And both these two great questions are importantly ethical, not primarily scientific or medical. They do depend on the facts, but the facts don't resolve them. So, you know, for example, is a 1% mortality too high? Or does a 1% mortality justify a societal lockdown? That's an ethical question. So to begin with the ventilator question, you're all now familiar with the ventilator shortages that occurred early on in the pandemic throughout the world. In Italy, at the very beginning, doctors were proposing to restrict ventilators to younger patients, and this caused an enormous pushback and outcry. And Marco Vigano, who was the head of the Intensive Care Society, who proposed, along with that society, that guideline, received considerable personal abuse, and we wrote a paper on the principles with him, which I'll go through in a moment. Now, you're all familiar with this kind of graph. It shows that COVID-19 is essentially an age-related disease. And it's been the case that since the beginning of the pandemic, it's essentially a disease of the elderly. 90% of cases occur in those over 65, and half of those deaths are in those aged over 85. So the biggest risk factor for death from COVID is being older, and that even compares to being unvaccinated. So vaccination hasn't changed that that phenomenon. 84% of recent deaths are still in those over the age of 65. And you'll see in the bottom right-hand corner, even the lowest vaccination death rate over 50 outstrips the unvaccinated death rate in under 50s. So there are other risk factors, other comorbidities, obesity, being in an ethnic minority group, having a low socioeconomic status, or being male, but the strongest is vaccination. So the proposal to restrict ventilators according to age, as one example of using a risk factor, has met with considerable resistance. So David Archard, head of the Nuffield Council in the United Kingdom, said to discriminate between patients on the grounds of age is to send a message about the value of old people, and it would be hard not to think, even if it was not intended, that a cull of elderly people was what was being aimed at. So I want to resist that position and argue that we should use certain risk factors. One approach to this, which is typical of the sort of public rhetoric, is to simply avoid the question. So this is the governor of New York, who says, to me, I say the cost of a human life is priceless, period. Now, every life has a value, and there's a maximum amount we will spend to save a human life. There are financial instruments to value lives. And the reason that we do this, in part, is because in a life-threatening pandemic, where life-saving resources equal numbers of lives. So to take a banal example, if one person's life-threatening disease costs $100,000 to save, and 5 people's lives cost $20,000, with a fixed resource, you're faced with saving 1 or 5 people. So money equals numbers. Another reason to take probability into account is for the same reason, that probability equates to numbers. So if 5 people have a disease with a 60% chance of cure, and 5 people have a different disease with an 80% chance of cure, with the same amount of money, we can save 4 lives rather than 3. So according to utilitarianism, we should save the greatest number. Bentham's famous slogan was the greatest good to the greatest number. And in fact, this is how health systems are often structured, to maximize the number of quality adjusted life years, or to set a threshold in the amount we will pay to save a quality adjusted life year. According to egalitarianism, however, there should be equal treatment for equal need. And as John Harris has put it, what each person rationally desires is the greatest chance of the longest, best quality of life for him or her. So for the person who has only a 60% chance of being cured, it doesn't matter to them that somebody else has an 80% chance. That 60% chance is all they have. And egalitarianism speaks in favour of an equal share of health resources, and this is the stated basis of many public health systems, even though in practice they allocate resources according to utilitarianism. So these are some of the quality adjusted life kind of impacts of various interventions. And every country has a threshold on how much they will spend. In Australia and the US, it's typically around $50,000, and the UK spends $20,000 to $30,000. I think Singapore has a similar sort of figure. Now, quality adjusted life years and utilitarianism has been criticised as being discriminatory giving those with the poorer prognosis, those who are older, who have lower quality of life, lower priority. And I'll come to those objections in a moment. So how should we make a decision about how to allocate ventilators? Should we use something like egalitarianism and give everyone an equal chance of the ventilator regardless of their age or their lifestyle? Or should we adopt something more utilitarian? So we've described this process called collective reflective equilibrium that is based on John Rawls's famous procedure of reflective equilibrium that involves using preferences or intuitions from the public through either surveys, focus groups, citizens' juries, and intuitions of experts, but bringing these together with a range of normative frameworks such as ethical theories, mid-level principles, guidelines, and declarations to create as a maximally stable coherence. So in this example, I'm going to show you some of the surveys we did with the general public and the application of several ethical theories and how it can generate policy. So we did a survey in the UK of the British public of around 763 people during the pandemic and asked them questions like this, that, you know, you're in charge of ICU. There are 2 patients who need a bed. There's only 1 bed. One patient has an 80% chance of surviving. Another patient has a 10% chance of surviving. Should you give the bed to patient A or the bed to patient B, or toss a coin to decide? You can see in this case, the vast number of people are utilitarian and choose to give the bed to the patient with a greater chance of survival. So here are the probability, or some of the probability data that we achieved. So you'll see that people are utilitarian unless the chances of survival are very similar. Say one patient has a 51% chance and the other has a 49% chance. So it's only when the probabilities are very similar do people start to become egalitarian and choose to give people equal chances over those with a better prognosis. And this mirrors research we did several years ago before the pandemic on allocating neonatal intensive care beds, where the public were overwhelmingly utilitarian unless the differences were very similar. Here is the effect of age. Again, people, 80% of people would give a bed to a 55-year-old rather than an 82-year-old. And similarly, when the difference was 82 versus 66. And it's only when the differences in age are very similar, 71 or 72, do people become predominantly egalitarian. Here is the difference in age at younger ages, and people are similarly predominantly utilitarian. When it comes to quality of life, we asked them about various levels of disability based on standard scales, and people were still predominantly utilitarian, although less so in this survey than they were in the past survey, where they were extremely utilitarian across all comparisons of disability. That was offering treatment to people with disability. So again, here you see those figures in a different format. We also asked people whether they would be prepared to withdraw life-sustaining treatment such as ventilation to make way for a better prognosis patient. And standardly, doctors are reluctant to withdraw treatment to people who have already commenced treatment. They draw a distinction between withdrawing and withholding ventilation. But the public, again, were highly utilitarian, and if there were better prognosis patients, they were prepared to withdraw ventilation. When asked about duration of treatment, so again, duration of treatment equates to numbers of lives. If you have one person who needs a ventilator for 2 weeks and 2 people who need it for 1 week, you're faced with the choice of saving 2 versus 1. And so when we pointed this fact out, people again were strongly in favour of the utilitarian option. And again, that's consistent with previous research. However, this is not how resources are allocated. Resources are allocated typically on a first come, first served basis, which is an egalitarian procedure. But this implies that people with poorer prognosis requiring long periods of treatment at the expense of patients arriving with much better prognoses. And it will inevitably lead to a reduction in the number of lives saved. So I want to compare now this public intuition that we should allocate resources according to utilitarian procedure with this first come, first served principle that medicine uses. It's important to note that this is also unfair because when someone happens to fall ill earlier or later, makes no moral difference. According to a principle of temporal neutrality, when a harm occurs makes no moral difference. But nonetheless, it's frequently used. Now, in the paper that we wrote with Marco Vigano, we argued that there's a basic moral intuition that we should save more people. The standard philosophical example of this that goes back to John Torek is that you're in charge of a Coast Guard rescue boat. You can only go in one direction. If you go north, there are 5 people on a raft, or if you go south, there's a single person. You can only rescue one. Which direction should you go? When we asked people in that previous survey, 98% of them said you should save the 5. Egalitarianism says you should toss a coin because tossing a coin gives all 6 people a 50% chance of surviving. So according to utilitarianism, resources should be distributed to bring about the greatest good to the greatest number. But it's important that not only do utilitarian theories recognize this principle, but for example, contractualist approaches support this. So if you didn't know whether you were going to be the single individual on the raft or one of the 5, what policy would you want the Coast Guard to employ? You would want the policy to be to save the greatest number, because this gives you a 5 in 6 chance behind what's called the veil of ignorance of being rescued. So in this case, rational self-interest coincides with utilitarianism. So both contractualism and utilitarianism support the principle of saving the greatest number of lives. And so we call this a universal requirement of rationing. Even though egalitarianism may not support this, we have a convergence here between public opinion and utilitarianism and contractualism. So the implications of saving the greatest number of lives are twofold. First of all, it implies we should save patients with a greater probability of survival, because as I said, if Group A has a 90% chance of surviving and Group B has a 10% chance, you're faced with saving 9 people or 1 person for every 10 that you attempt to save. It also implies that you should give priority to patients who require life-saving resources for a shorter period of time, because that equates to numbers, as I said before. So on the basis of this, we argued that whatever your ethical or reasonable ethical perspective, you ought to accept a principle of saving the greatest number of lives. And this will imply saving people with a better prognosis, chance of surviving, and those who need resources for a shorter period of time. So on the basis of this, we described this algorithm in this paper in the British Journal of Anaesthesia early on. And you only have to essentially look at the yellow boxes, but it involves a first obligatory triage step of evaluating the probability of survival and also the length of requirement of that particular resource for all patients. And comorbidity, frailty, biological age are all determinants of probability of survival. So age can be taken into account in this indirect way. And then if there are still too many people requiring the resource, we describe a number of optional steps. So what we've argued is that this first stage of saving the greatest number should be obligatory. And then the optional steps are either to go straight down to a second triage involving length and quality of life, which would be utilitarian, or adopting a non-utilitarian strategy, such as a trial of treatment for a fixed period, a pure lottery, which is egalitarian, or giving priority to healthcare workers based either on grounds of utility or desert, or giving priority to younger patients on the grounds of desert, that those patients have had fewer years of life. So any of these options have some more contested defence, but the allocation, according to Save the Greatest Numbers, has the greatest convergence between public intuition and plausible moral theory. So in this way, we can develop strategies that have both obligatory decision procedures and then optional according to the particular weight people want to place on a different theory or principle. And I think this kind of algorithm makes it transparent how we're valuing life, and also is capable of revision. So this would be a purely utilitarian way of making decisions. We've also applied this to sorry, this would be the utilitarian strategy in greater detail. So that's the kind of work we've been doing in Oxford in an attempt to sort of bring a structured answer to these questions of bringing together popular opinion or intuition together with a range of moral theories to create decision trees. I now want to just move on to mandatory vaccination, which I think raises some other interesting ethical issues. So let me just pass on to that presentation. I should have made the mistake of not shutting down all of my PowerPoint slides before. Oh, that's right, I think I have to end show. Okay, and change to mandatory vaccination. And now share. Okay, so mandatory vaccination. Back in early 2020, before we had vaccines, I started to look at how I predicted that we would need mandatory vaccination and how we might make these decisions, and wrote this paper where I compared mandatory vaccination to incentives, financial incentives for vaccination. Now, the issue of vaccination or mandatory vaccination is just one example of the use of state coercion. And the standard justification for state coercion is that it can be used to prevent one individual threatening another. Harm to self is never a sufficient warrant, as John Stuart Mill famously said. And a number of years ago, I gave an example of a child going to school with a bottle of toxic bleach. The bleach can be taken away from the child because of the threat it poses to other children. And Jessica Flanagan has an example, a similar way, of a person firing a loaded gun into the air in a crowd. Infectious disease is a case of one individual passing on an invisible lethal threat to others in the form of a potentially lethal virus. And so this is the basis for coercion such as lockdown, quarantine, and mandatory vaccination. So when it comes to a pandemic, time is lives. It takes, the longer it takes to achieve sufficient protection, the more people die. At the time I wrote this, 5 people a day were dying. Now, these are old figures that prior to the introduction of vaccines suggested considerable vaccine hesitancy, and that figure has been borne out, at least in the US, but many other countries such as Germany and Austria are facing problems of significant vaccine hesitancy. There are other coercive practices in the public interest, and I've written a paper that analogizes mandatory vaccination to mandatory seatbelt laws. In the US, 50% of Americans oppose mandatory seatbelt laws, but now that they've been introduced, 70% believe they're justified. Seatbelts reduce the chance of death by 50%. They may cause death, so-called seatbelt syndrome, and but the chances of being benefit are vastly outweighed by wearing them. And importantly, they protect other occupants in the car. So they are mandatory and people are fined if they don't wear them. So the argument in this paper was that, you know, if vaccines were as safe and as effective as seatbelts, they could be made mandatory. In the cases of other vaccines, other countries have employed mandatory vaccination. Australia has a no jab, no pay. That is no jab, no childcare benefits unless a child is vaccinated. In Italy, childhood vaccination is required and people must pay a fine of €600. And in the US, mandatory vaccination is required for school entrance in several states. And I draw a distinction between mandatory vaccination, that is associating a cost with not being vaccinated, such as a fine or restriction of movement, versus compulsory, which is holding somebody down and forcibly vaccinating them. And I think the basis of a mandatory vaccination can be called what can be called a collective duty of easy rescue. When the cost to an individual is small and the benefit to others is large, that duty can be mandatorily imposed. So one example would be organ donation. Singapore has an opt-out system, but I think organ donation could be made mandatory because the cost to an individual is zero and the benefit to others is saving of 7 or 8 lives. So at the time of writing this article, I constructed this algorithm, which has 4 stages, which outline the 4 requirements that need to be met before vaccination can be mandatory. The first is that there's a grave public health problem. The second is that there's a high level of confidence in vaccine safety and efficacy. Third, that the comparative expected utility of a mandatory policy is greater than all less coercive alternatives. And lastly, that the costs are proportionate to the safety and effectiveness of the vaccine and the gravity of the problem and the relative comparative utility. So the question is, do the vaccines for COVID-19 meet these requirements? And at the time of writing this and subsequently, I predicted that the requirements wouldn't be met for one major reason. But the first question you could ask is the gravity of the problem so great that that it requires mandatory vaccination? And so far, there have been 4 million deaths, and it's been predicted that 500,000 people would have died in the UK. And even with the introduction of highly restrictive lockdown measures, over 200,000 people have died, and it's estimated that 200,000 further people will die from non-COVID related causes due to the restrictions. So if you look at the numbers of people who have died in England and Wales during 2020, it looks like a catastrophic pandemic. It's similar to the number of civilians who died during World War I, and even higher than the number that died in the Second World War as civilians. And if you look at the excess mortality, which compares the mortality in 1 year to the previous 5 years, it's one of the worst, 3 or 4 events in the 20th century. So if you look at that, this is an extremely severe problem. However, there are other ways of measuring severity. So just to take Sweden in April 2020, which was the highest point of the pandemic for Sweden, its death rate was surpassed in the months of 1993 and 2000. And if you look at instead of the numbers of deaths, because of course there are vastly more people today living in the UK than there were in 1920 or 1940. If you look at your chance of dying in the UK during 2020, it was roughly 1%, which was admittedly much higher than the previous 5 years. That's why the excess mortality is so high. But it's higher than every other year except those years after 2003. So your chances of dying were still much lower. in 2020 than in 2003 or 2002 or in 1980. So on these figures, there's cause to question the gravity of the pandemic. But more importantly than that, I predicted it at the beginning that there would be long-term safety issues that would need to be resolved with two completely novel vaccines, the mRNA and modified adenovirus vaccines. So I predicted mainly on the risk of unknown side effects that mandatory vaccination would be difficult to introduce. And indeed, we've seen side effects both with the mRNA and with the adenovirus vaccines. However, my barometer now, after these have been introduced, over for nearly a year, is that we probably do have a stable enough safety profile to make them mandatory. So I think that the possibility of mandatory vaccination is more justifiable now as we have better data on long-term safety. These are the alternative strategies that you can employ besides mandatory vaccination. And you'll see in there, one of them is incentivized vaccination, which some countries have used. And there is, I think, a balance of evidence in favor of them. One recent study that came out in Science showed that offering people money in Sweden would influence their willingness to be vaccinated. One estimate of Vax Lotto in Ohio that paid people $1 million in a lottery for the vaccinated showed it saved 30 million in costs. So I think, and I argued in this paper that incentivization, when the safety profile of the vaccines was uncertain, was a more ethical strategy than making something mandatory. These are the kinds of coercive practices that you can employ, the range of costs. And what's important for a country like Singapore contemplating the introduction of mandatory vaccination is that the costs should be proportionate to the gravity of the problem and the safety and effectiveness of the vaccines. So losing your job is different from paying a small fine. And you often hear this principle of the least restrictive alternative. The problem with the least restrictive alternative that we should adopt the alternative that involves the least restriction of liberty to achieve a public health goal is that usually more restriction of liberty leads to more public health. So there's no doubt that you can reduce the number of COVID-related deaths by imposing significant lockdowns, even now. The question is the proportionate gain worth the loss in liberty? And so proportionality is one of the key ethical issues that hasn't been addressed in the pandemic. And that is a very complicated question. And I've argued in favour of easy rescue, that the costs have to be small relative to large collective benefit. So mandatory vaccination could be justified. I think we probably do have a sort of stable enough safety profile now to introduce it. But I want to finish with this proposal, which Owen has said. But early on in the pandemic, I also wrote a paper arguing that lockdown could be selective rather than general. That since those who are most likely to become ill are the elderly, it would make ethical sense to restrict the movement of the elderly to protect them from being infected. So they have the most amount to gain from various forms of lockdown and quarantine, and younger populations have the least to gain. So in fact, there are two ways in which you can justify coercion in a pandemic. Directly, as I said, by preventing others from an individual from infecting others, the standard justification. But in fact, the vaccines are very poor, relatively poor at reducing transmission. They only reduce transmission by about 40%. And as we've seen with Omicron, it's hugely infectious and transmission is inevitable. And the main justification for coercion has been a different one, an indirect justification to protect limited public health resources. So the UK slogan was stay at home, protect the NHS, save lives. But it's not going to be the younger populations who are going to be putting pressure on health resources. It's going to be those over the age of 65 or those over the age of 50. So I argued in that paper that this indirect pressure would be a justification for limiting the freedom of those who are older and more likely to put pressure on hospital resources. And the same argument applies to mandatory vaccination. Instead of having mandatory vaccination for all of the population, you could make mandatory vaccination apply to only those over the age of 50 or only over the age of 65 to protect health resources. Because the rescue for a young person is much more costly. The risks of the vaccine loom large for a young person compared to the benefits, whereas for the older person, the benefits of the vaccine are vastly greater and the risks are relatively much smaller. So it's a much easier rescue for the elderly than it is for younger people. So one of the kind of initiatives that I've tried to introduce is the idea of selective coercion, either selective lockdown, selective quarantine, or selective mandatory vaccination as a way of promoting liberty, but also reducing pressure on the health service. Now, this raises objections of discrimination and what's sometimes called double jeopardy, doubly disadvantaging communities which are at increased risk, such as Black, Asian, and other ethnic minority groups in the West, who are at greater risk through background structural injustice. And these are important objections, but maybe I'll finish there and leave it to you to develop those or provide other objections. So I think selective restriction of liberty is something that could and should have been embraced during the pandemic. Thank you.
Okay, thanks very much, Julian, for that double header talk, I guess, on ventilators and vaccines. So, so a lot of really great material to reflect on. Yes, open the floor to questions now. Could either use the raise hand function, or if you prefer, you can use the chat. I think it's always better to have the raise hand function. So folks have questions, use raise hand. John, I can start off with something, and while people are thinking their questions, they can post their hand or their questions in the comments. So I want to loop back to the first part of the talk on the ICU question, and at one point you highlighted quite rightly that in the real world, right, first come first serve seemed to be dominant, even in cases where there was were ICU shortages. And I guess this question is there that mismatch between the theory that converges for prioritizing those who need most and reality. But I mean, my understanding is that the first come first serve was not a sort of ideological or ethical decision, but a pragmatic one, right? Because when someone presents to that, it's because you have non-simultaneous presentation to the ICU. That's the fundamental problem, right? You have generally 5 different people with competing needs presenting at the same time at different hours of the day. Someone will come in and you don't know necessarily what the rest of the day their needs are going to be. You can project and you could create averages, but there's a worry, of course, that if you project and you hold the ICU for someone, you don't give it to somebody who might need it, but you think someone needs it more, and then nobody shows up who needs it more, and then you kind of failed to save a life or failed to potentially save a life when you could have. So that's like a one side of thing. And that might just say, okay, that's fine. Then what you need to do is you need to send people to the ICU and then take them out when someone who needs it more comes in. But that seems like a somewhat different set of questions. I mean, I think one of your survey items got to this about withdrawal of ICU care, but most didn't. And there's a question of how robust that will be, when teased out in various iterations about whether this withdrawal question is going to be palatable. And my understanding is that because, as you say, physicians are extremely reluctant to withdraw care, that's not something that's been widely adopted. Yeah, so just get your thoughts on that aspect of ICU.
Yeah, I mean, you raise a very good point that it is a practical, way of quickly allocating resources. I think there is, for many people, a principle basis when people do see this as being egalitarian and avoiding difficult decisions about the value of life. And as you say, it does require a commitment to withdrawal of resources. If you want to make your ICU maximally efficient, you don't want to have a bed, unoccupied for a day. And in other empirical research that Dominic and I did, we found that the clinicians are unwilling to withdraw resources. So I think a good further project would be to deep dive into various withdrawal questions and issues, and indeed try to change this bias towards withholding rather than withdrawal, or we call it, the equivalence, or accepting equivalence of withholding and withdrawing. So I agree with you that if you think there's a very significant difference between withholding and withdrawing, there's a reason to just first come, first served. So I agree with you, but the public surprisingly have a great attraction to, and so we've done many of these surveys, not many, but 4 or 5, and we've done them on UK population and the US population, and also the Indian population, because you can do Indian samples in Mechanical Turk, and people are remarkably utilitarian. It's like, despite the fact that the majority of philosophers are not utilitarian, in this way, I think philosophers are out of touch with the sort of ordinary kind of folk moral reasoning.
Thanks. Okay, Markus, you have a question?
Yeah, thanks. So this will be an immediate follow-up, actually, to the question that was just raised by you, Owen. So the argument that I've heard also with regards to this kind of these thought experiments, that if you have 3 persons coming into the ICU simultaneously, it's unrealistic. Normally you have people coming in a sequence. And what happens then is that you establish a relationship as a physician between the patient and the physician. And that relationship matters. And it matters also for the matter, well, it matters for the question of whether to withdraw treatment or not. And that kind of is another factor that would play into the question of whether to withdraw or whether to continue treatment. So it's a relationship question, which I think the thought experiments don't quite get into. And then as an immediate follow-up to that, and this is kind of a minor quibble, you said that this kind of the methodology you followed is Rawlsian, and to me it seemed like it's Rawlsian in the sense, yes, you look at intuitions about particular cases, and you look at the principles that you follow, but you don't hold the individual stable between them. So again, this is a minor quibble, but I thought this reflective equilibrium that Rawls would have been after is actually a reflective equilibrium within individuals. So you ask one individual, what is your intuition about the case? And what is your intuition about a general principle? And then you try to bring the individual into a reflective equilibrium between potentially diverging intuitions about cases. And it is something that you cannot quite achieve, I guess, with tools like Mechanical Turk. That's just a methodological point, yes. Yeah,
it's not reflective equilibrium, as you say. I mean, Rawls talks about a group of competent judges or rational deliberators and a process that involves them. And so we're talking, and their intuitions. So that's why we call this a kind of collective reflective equilibrium in practice, is the sort of acronym that we use. It's basically using data from the public as the source of intuitions, not the intuitions. Well, it does use expert intuition and the intuitions of these rational deliberators, but that's not the only intuitions it uses. So because this has to be, defended in a kind of liberal democracy, we feel that kind of input is important. So it's different. I agree. It's not the same. With respect to your first point about relationship, yes, many doctors feel the relationship is extremely important. Then there's no doubt about that. But this goes 2 ways, and this concept of the importance of the established relationship can have very negative consequences. So what happens in practice is that doctors will refuse to take on a relationship because they don't want to end it. So actually what happens is you don't get a chance of intensive care because doctors don't want to be faced with this issue of withdrawal. So what happened in rationing is many people were just not sent to admitted to hospital. I was on a BBC documentary where someone who was 70, otherwise fit and healthy, was simply not sent to ICU, and the family saying, why not? They were fit and healthy. And if you have a bed available, you should be providing it to an 80-year-old or an 85-year-old rather than the bed being held vacant. But what happens because of this relationship question is the beds are empty because they don't want to be faced with this decision of breaking the relationship or withdrawing treatment. So you don't get a chance. And I'd rather have a chance if the bed is available and it be withdrawn than have no chance at all. So just with your point about, will they form a relationship? It depends on how kind of urgent the pandemic is. I think in Italy, there were cases where there were literally 3 or 4 people needing ventilators and you had to make a decision who was going to get it. So I think in some cases they are all there. And in India as well, I think you had these cases where you just did, people needing oxygen. There's just not enough oxygen for, so you will have to choose between patients. But I agree with you, as the urgency reduces, you're then left with this situation of prediction. And, another paper I've written early on is many patients in general are denied a trial of treatment because of this concern about the relationship and withdrawing their treatment. So what happens if you have a severe brain injury, doctors will often say, oh, well, we don't want to be left with a situation where this individual is on life support for a long period of time, or we have to make it difficult. We're just going to allow them to die. But if I had a severe brain injury, I'd want a month of treatment and then a reevaluation of our prognosis, and then withdrawal. If you have more information available, it's more rational to have a trial of treatment. So I think we should revise this idea of the special relationship with the existing patient, and be much more prepared to be flexible and consider the group, but also consider the rational self-interest of that individual. But I agree with you, the way you've described it is correct. And that is the standard view that there is something special about taking on responsibilities for this patient. And I think we should revise that.
Thanks. Other questions from the floor?
As an anecdote, my father was a very fit, healthy man, and he had an abdominal aortic aneurysm, operated on it when he was 80 with extremely good results in hospital for sort of 3 days. And then they thought he had a leaking aneurysm, which was a medical mistake. He didn't. He just had some gastritis from non-steroidals, but he was subjected to a laparotomy and developed, needed intensive care afterwards. So he was in intensive care for 2 or 3 weeks at the age of 82. He got out, did extremely well, lived another 5 or 6 years, entirely appropriate to put an 82-year-old in intensive care in that situation. But I'm sure, at the height of the pandemic, if you asked him, do you think you should be put in intensive care instead of the 70-year-old? And he would have said, no, the 70-year-old should get precedence. So even these age kind of limits are, need to be context specific. And that's why you do need clinical judgment. These are just guidelines that I'm providing, but they need to be interpreted in the light of the actual pressure on resources at the time, the actual individual, etc.
Thanks. Yeah. So other questions from the attendees? Adeline, yeah.
Thanks very much for the talk, Julian, and the insights. I just wonder about a comment you made. You said the survey data showed that the public was surprisingly utilitarian, right, in its how it would allocate resources. Do you think this is a function of the particular context of the COVID pandemic and of the extent to which it is life-threatening and these decisions need to be made, or do you think it reflects a broader kind of approach in their minds?
I think it reflects a broader approach. I think Markus is there. I think if you did this to the German public, you would get a different set of results. We haven't done it with Germans, but there's a survey of 40 million preferences called the Moral Machine Experiment about the programming of driverless cars, and that is overwhelmingly utilitarian, down to giving priority to individuals with higher social state or higher social utility, of penalising lawbreakers. So even when you look at 40 million people from all around the globe, you see the strongest preference people have is to save humans over animals. But then after that, it's to save the greatest number of humans And then after that, it's to save younger rather than older people. And those three, it doesn't matter whether you're in China or South America. The fourth one is to save law abiders rather than lawbreakers. So these preferences are extremely stable. Now, countries do have cultural variation. So, for example, women are given greater priority in South America than in other countries. There may be a number of reasons for that. The elderly are given greater priority in China and Asian countries than in other parts of the world. But there's still an overwhelming, kind of preference for the younger. So you might say, oh, well, that's still a life-threatening event. Who dies in a trade-off accident with driverless cars? But we also did surveys, which I haven't presented here, on vaccine allocation and taking into account ethnicity and race, because we wanted to see, do people think that, people from racial minorities should be given special weight in the allocation of vaccines when they're limited? And do people think that people with obesity should be given, greater weight or lesser weight? And in these cases, people take these factors into account to a much lesser degree than you would expect. So when it comes to race, they might use it as a tiebreaker, but they wouldn't be prepared to pay in terms of utility or choose, deny a more vulnerable person in order to give it to somebody who is Black or has suffered racial injustice. So in general, even when it comes to the allocation of vaccines, what matters most to people is just, saving lives rather than structural injustice or perceived responsibility, for example, in obesity. So these other factors are much less important to them. So I think it does, show that people have a broadly consequentialist psychology, but these are just a handful of surveys. But what's important is that it's also present in Asia. It's not just a phenomenon of the US or the UK. And while I don't want you to think that, how we should decide policy is to do a survey of people. That's not what I'm suggesting. But what I am suggesting is where you've got a controversial issue like value of life, and there's coherence between a reasonable set of ethical theories or principles and public intuition, that's a stronger basis for policy than either taking the intuitions of a group of philosophers that are out of kilter with the intuitions of the public, or just picking a particular theory that has no coherence with public intuition. So, in driverless cars, the public and we think there should be essentially a utilitarian, or save the greatest number approach. The Germans have said explicitly that you cannot involve innocent parties in trade-off accidents, even to save a greater number of lives. And you can't take any characteristic like age or disability or anything like that into account. And so the Germans have adopted for this highly egalitarian approach to driverless cars that is consistent with their approach to terrorism, where they've said, we will not shoot down a plane, even if it's going to kill 10,000 people, because we cannot intentionally kill 300 innocent people. Whereas the British would shoot the plane out of the air. Tony Blair already had scrambled the Air Force to shoot a plane when it went off radar after 9/11. So there are different orientations between countries, but not as great as you'd think.
I think we have time for one more question.
I'm interested in people's view. Do you think that if let's say you can adopt policy A, which applies to everyone, that involves blanket coercion like a lockdown or mandatory vaccination, or you can adopt B, which is targeted to the vulnerable or the elderly, and that it will save fewer lives, but not that many fewer lives, and substantial proportion of the population will be free. There'll be greater economic benefits. There'll be fewer non-COVID related morbidity and mortality. Do you think that that option that the general policy is preferable, or the more restricted policy is preferable? That will have, slightly more COVID-related deaths.
Sorry, can I just clarify? So even under the restrictive option, under the moderate option, would essential services still be accessible for the non-vaccinated?
Yeah.
Yes. Okay.
But we did a survey. I mean, I did some modelling at the pandemic with Australians before there were vaccines that showed if you let everyone, I could ask you this one, everyone under the age of 50 to just circulate freely, socialise, and work normally, have no restrictions. And this is at the height of the pandemic, but restrict those at the age of over the age of 50 as they were restricted during the pandemic, and you would have a higher mortality than the blanket lockdown that was imposed, but the health services would continue to be able to run, and you would have a mortality from COVID that was similar to April 2020, which was sustainable. So you would have more deaths. So you would have something like 100,000 deaths instead of, say, a projected 50,000 deaths, but you would be able to release those under the age of 50. Do you think such a policy would be ethical?
I guess we don't have a poll function here, so we can put up for the audience. But I mean, I guess the question kind of presumes a certain you assume you can determine the outcomes already. But in the real world, right, we're not going to know with such certainty that these are going to be the consequences of these policy options. We actually, particularly early on, but even today, we live in high degree of uncertainty about the consequences in terms of lives saved, in terms of economic impact, in terms of child development, et cetera, of lockdowns and so forth. So I mean, it's a bit difficult when you kind of have a very precise set of consequences. What does that imply for conditions in the real world where it's highly uncertain? And you might get very different answers, and reasonably so, when you ask questions in two different ways. I mean, in Singapore, there was a survey by the IPS on a variety of aspects of COVID measures, and one of the questions was a vague question. I think it's kind of appropriate that it was vague, which was about essentially whether it's appropriate to have more severe lockdowns in order to save more lives, but that would curtail economic activity, right? It was described in a vague way, not about precise GDP effect or precise numbers, but just vaguely, right? And then people kind of, in response to this vague question, they were generally in favor of saving lives over, promoting economy and freedom, which is consonant with Singapore's general approach. And that might be, I don't know, is that going to be more sensitive to people's actual values in the real conditions compared to these very precise consequentialist approaches when you kind of weigh out the cost of lives in numbers, when people might naturally then lean more utilitarian? I don't know.
Yeah, I think the problem that there has been in the pandemic is it's only COVID related lives that have been counted, and there hasn't been modeling of non-COVID related deaths to any great extent. And I think that this trade-off between the economy versus lives is in lots of ways a false and misleading one. So I think it should have been modelled in terms of overall deaths and morbidity and quality adjusted life years of lockdown versus no lockdown, and I think that may give you different answers. But that's interesting. I was just saying to Tamara, for our AI grant, I mean, you're on Zeke's paper. I think we need to have some discussion of the importance of values in futility decisions. So I've sketched, my approach, but I think, what we do need for that grant at the beginning is to have, maybe a summary of your paper with Zeke and how that applies to an algorithm for treatment limitation decisions in emergency care.
Yeah, thanks. I mean, for context, some of us are putting in for an AISG grant on governance principles. Okay, I think that's all the time we have. So thanks for the little tidbit at the end to link this with some other projects we're working on. I'd just like to thank Julian, for the kind of doubleheader talk, and everyone here for your participation. Hope you found this, interesting food for thought, and of course continues to be relevant, particularly the vaccine mandate. I guess with the ICU, we kind of hope in Singapore that question hasn't been motorized, but with the vaccine mandate, that continues to be a live issue. Questions about whether to make boosters mandated and whether to mandate now that children are eligible, whether to extend mandates to them and so forth. So I think these are very pressing and relevant questions in Singapore and around the world. So very much appreciate the insights you've given. I think we're going to close the session there. Adeline, was there any final word? Are there points before we close?
No final word, just to thank Julian again, and thank you, Owen, for facilitating the discussion. Thanks everyone for attending.